So we'll get going here. Thank you everyone for joining us on this beautiful afternoon. We will be recording this lecture, and we will be sending it out to everyone who has registered. So today's virtual community lecture will be given by Dr. Brandon Erickson. Dr. Erickson is a board-certified, fellowship-trained orthopedic surgeon specializing in sports-related injuries of both athletes and non-athletes alike. He completed his residency in orthopedic surgery at Rush University Medical Center in Chicago, followed by a sports medicine fellowship at the Hospital for Special Surgery in New York. During his fellowship, Dr. Erickson served as one of the assistant team physicians for the New York Mets. Dr. Erickson is a New Jersey native and has played football for the University of Notre Dame as a wide receiver. As an athlete himself, Dr. Erickson's goal is to get his patients back to the playing field while utilizing the most advanced treatment options. While Dr. Erickson treats athletes at all levels, from high school to college to professional to weekend warriors, he also specializes in non-athletic conditions of the shoulder, elbow, and knee. These include degenerative conditions of the shoulder, such as rotator cuff tears and shoulder arthritis, knee issues such as meniscus tears, ligament damage, and cartilage damage, and elbow problems, including biceps and triceps tears, ligament tears, tennis elbow, and elbow arthritis. His research efforts focus on shoulder, knee, and elbow conditions, especially those affecting the throwing athlete. Through his work with Major League Baseball, he has been able to better define injury patterns and treatment outcomes in elite level overhead athletes. He plans to continue his research to further the understanding of youth injuries, including methods of prevention to keep young athletes healthy. Dr. Erickson currently serves as one of the assistant team physicians for the Philadelphia Phillies and has recently been elected to the advisory committee for MLB PitchSmart. Dr. Erickson sees patients in our Tarrytown office that is located at 658 White Plains Road in Tarrytown, at 450 Mamaroneck Avenue in Harrison, and 645 Madison Avenue in Manhattan. The topic Dr. Erickson will be speaking on today is rotator cuff tears, what you need to know. And if you have any questions throughout the lecture, you can type them in the Q&A section at the bottom of the screen. And at the end of the presentation, Dr. Erickson will answer them. Perfect.
Got it? Okay. So, great. All right. So, as John said, my name is Brandon Erickson. I'm one of the sports and shoulder surgeons here at Rothman. And we're going to talk a little bit today about rotator cuff tears, what you should really know about these tears. And please feel free to chime in at any time. You can email questions or put your questions in the chat so that John can see them. And John, feel free to stop me at any point, and we can certainly address anyone's questions. These are my disclosures. They're not particularly relevant to this talk. And so as far as what I think we should discuss, so we're going to start with an anatomy review. We'll go over a history and physical exam of what people usually present with who have rotator cuff tears. You can see if this kind of jives with what you're feeling, some imaging that we see and why we get certain imaging, and then some treatment options on how we can treat these. And so if we think about the shoulder to start with, the shoulder is really made up of four joints. So there's a glenohumeral joint, which is the ball and socket joint. There's the scapulothoracic joint, which is your shoulder blade joint, and then your AC and your SC joints. And of course, we're talking about the glenohumeral joint today. And the main function of that joint is really to position your hand in space. So if you think about what the shoulder does, yes, it lifts your arm up, but its main function is to move your hand so that you can then grasp things, do other activities. And so that's the main purpose of the shoulder. Now, the way it does that is the rotator cuff really serves most of the purpose here. And what the rotator cuff is, it's 4 different muscles that help move your shoulder and position it in space. And so the 4 different muscles are the subscap, which is the one in the front, the supraspinatus on the top, the infraspinatus, which goes a little more towards the back, and then one called the teres minor, which is a little bit further in the back. And when you hear people talk about rotator cuff tears, you generally hear people talk about the supra or supraspinatus tear. That's the most common one that we see. And that's the most easy one to recognize because it's very difficult to lift your arm up this way. But if you have problems going either out or in with your shoulder, that can be an issue with a different rotator cuff muscle. And what they are, they're muscles that come off of your shoulder blade. They turn into tendons as they insert on the bone. And that picture there is just what it looks like when they insert on the humerus. And so if we think about what each muscle does, we can look here, and this kind of lays it out for you what each one does. So the supraspinatus is the one that helps you lift your arm up in forward elevation. The infraspinatus lets you rotate your arm out at the side. The teres minor lets you rotate your arm out with your arm at 90 degrees here. So very important in pictures or for doing your hair. And then the subscapularis pulls the arm in like this. So those are what the different rotator cuff muscles do. And again, if you have a tear in one of those tendons, you can see what specific shoulder motions would be affected. And if you have a tear in multiple tendons, then you can have a lot of shoulder motions that are affected. Now, one of the biggest factors of how we treat these is what your activity level is like. Are you Jake DeGrom or Zach Wheeler and pitching for the Mets or the Phillies? Or are you just a recreational athlete like I am now that just plays sports on the weekends and has some shoulder discomfort? And how we treat these is very different between those 2 different patients. If it's an overhead athlete who has a shoulder problem or a rotator cuff tear, specifically a baseball pitcher, we do everything in our power to get these guys back without operating on their shoulder because we know that the results just aren't very good if we operate on their shoulder. So we have them in physical therapy and physical therapy and physical therapy. We give them injections, all kinds of different stuff because we really don't want to operate on their shoulder. Now, generally also for patients like us, we're still treating people conservatively at the start, but oftentimes surgery has a much more reliable outcome rather than if somebody's an overhead athlete. So let's talk about kind of the more mature patients. So kind of the 35-year-old and up recreational athlete or just general patient. So we know that rotator cuff tears are very common in this population. Actually, if you went out and you took 100 people off the street and got MRIs on all of them, you'd probably find about 30 or 40% of people actually have a rotator cuff tear and they have no symptoms at all. So just because you have a rotator cuff tear doesn't mean you have to have it fixed and doesn't mean that's necessarily the cause of your shoulder symptoms. It's something very important to understand because a lot of people will come to me with MRIs and they'll say, listen, doc, I have a rotator cuff tear. It's got to be fixed. And their symptoms are more because of their biceps. Their symptoms are more because their shoulder blade is not moving properly. And so with a couple of different conservative treatment strategies, we actually can get the shoulder a lot better. And I don't actually have to operate on their shoulder. That's not uncommon, okay? So I just don't want you to think, oh, I have a rotator cuff tear, I need surgery. It's not true. Now, from a history perspective and what I hear when I talk to patients who have a rotator cuff tear, I want to know a couple of things. I want to know how old you are. Is it your dominant arm, male, female, and what's your activity level? What are your goals of getting back to? Are you trying to get back to recreational activities of tennis? Or are you a manual laborer who really needs the shoulder for your job? What kind of stresses do you put on the shoulder? All of that's very important. A lot of people come see me with shoulder pain because it starts bothering them at night. It's starting to wake them up at night, and this causes them a problem. And so that's honestly one of the reasons people oftentimes will come see me. Now, the other question is, was this an injury that happened, or did it just happen over time? If it just happened over time, we call that kind of insidious onset. Those often respond quite well to conservative treatment. If you had a fall and then you have this new massive rotator cuff tear that happened because of the fall, those don't respond quite as well to conservative management. So those ones are sometimes ones that we'll fix. Have you had any imaging in the past? So what can I look at from before and compare it to now to see if anything's changed? And then what treatments have you had? Have you done some anti-inflammatories? Have you had any injections? Did you have any therapy? Have you had surgery in the past? These are all relevant things. So when we have our initial consultation, these are things that we talk about. And then I'll examine you. And then I want to see a few things. What's your motion like? Can you lift your arm up overhead? If you can lift your arm up overhead, that's usually a pretty good sign. Sometimes you can't because it's limited by pain, or sometimes you can't because it's stiff. Now, when people have rotator cuff tears, generally they have a hard time lifting their arm up, but when I try to lift it up in the office, it goes up just fine, it's no problem. And that's because you are not stiff, your shoulder is not stiff, it's just that things aren't connected properly, so they're not moving the shoulder properly. If I see you and I can't lift your shoulder up either, that's generally not a rotator cuff problem. That's actually something called adhesive capsulitis or frozen shoulder, okay? And that's relevant because that generally responds very well to a steroid injection and some physical therapy. Then I'll test the strength of your rotator cuff. And oftentimes, if you have a rotator cuff tear, it'll be weak when I test it, okay? We'll notice weakness on testing of specific things when I see you, and that oftentimes can indicate a rotator cuff tear. We'll also check your biceps. We check your AC joint, which is the joint on top of your shoulder, okay? And then I also have to examine your neck. I want to see if the neck is causing some problems with the shoulder, because the neck and shoulder are very intimately related. Just like the hip and back, the neck and shoulder are very intimately related. So it's very relevant to make sure that it's not actually a neck problem that's causing your shoulder issues. And so if we take a look here at the different imaging studies that we get on people, what we do is we want to look at x-rays. Sometimes we get an MRI, not usually an MRI, which is an arthrogram where we shoot dye into your joint, or an ultrasound sometimes we can get. And in the right hands, an ultrasound can be very effective. So when you see me in the office, I always get x-rays in everybody's shoulder. And I have a lot of people that ask me, I don't want to get x-rays. I don't need x-rays. It's not a bone problem. It's a soft tissue problem. I have a rotator cuff tear. And I totally understand that, but it's actually, you can actually find out a lot about somebody's shoulder by just getting simple x-rays. You can see here, this is an x-ray of somebody's shoulder. This is a completely normal x-ray, okay? Somebody comes in, they have this x-ray, it's not a bony problem, right? Somebody can come in sometimes and think they have a rotator cuff problem, and they come in with this x-ray. Well, you'll notice now that ball is no longer centered in the socket, and it is riding up against that bone on top of your shoulder. And that's happened because you've had a rotator cuff tear that's been there for a really, really long time. And so this is a very important finding that I can find out just by looking at your x-ray. If we look here, this is an x-ray of somebody that has shoulder arthritis. You can see all this extra bone that's around that black dot down here. That doesn't belong there. That shouldn't be there. And what can happen is that extra bone can actually cause a mechanical block to your motion. So you can think that you're not powering the shoulder properly because your rotator cuff is torn, but actually you just have a mechanical block, and that's what's causing your issue. And then lastly, we can also see some arthritis in the joint above your shoulder, what's called your AC joint, and that can sometimes present with a lot of shoulder pain. And so it's these types of things that we pick up on x-rays that can actually be quite relevant and help us when we're treating you. So these are why x-rays can be very important. But let's say we get x-rays and we're not exactly sure what's going on. They look fine and you've done some conservative treatment, and then we move on to some other imaging. Well, that's usually an MRI for the shoulder. What the MRI can show me is, what does the rotator cuff look like? Is it attached to where it belongs? Has it been torn for a really long time, so much so that your muscle is actually starting to turn to fat, which is a big problem because if I try to fix that, that doesn't do so great. And do you have anything else going on with the shoulder? Does your biceps look inflamed? Is your cartilage beaten up? Things like that. And if you take a look at this image here, this is an MRI of the shoulder. This black thing here, that's the rotator cuff tendon. That belongs attached all the way down here. So all this white gap here, that's where it happens when you have a rotator cuff tear and it retracts back. So what we do in surgery is we take this and we bring it back down to the bone. That's one that oftentimes benefits from surgery. If it's just a partial thickness tear, it doesn't always benefit from surgery. Those oftentimes get better. Now, when I mentioned to you muscle atrophy or kind of turning of muscle to fat, this is what that looks like on an MRI. This over here, this is what normal muscle looks like. It looks dark. You can see here it's starting to turn light. That's actually fat. And over time, if you have a rotator cuff that's been there for a while, it actually can turn to fat and be a problem. Okay. So we diagnosed you with a rotator cuff tear. Great. Now, what do we do? How do we treat you? Okay. Well, again, your symptoms matter, what your goals are, what your physical exam is like, and what your imaging looks like all kind of comes into play here. Okay. Now, we know that about half of rotator cuff tears will progress over time. About 50% will progress over time, okay? And so sometimes somebody will do well for a while with conservative treatment, and then their pain will come back or it'll start to get worse, and those sometimes will go in and fix. Now, from a non-operative perspective, the patients that do really well from non-operative treatment of cuff tears usually have partial thickness rotator cuff tears. They have small full thickness tears, so only a small portion of one of the tendons is torn, or they have chronic tears where the muscles turn to fat over time, and those actually respond well to conservative treatment. Operatively, these are the ones where somebody falls, had a normal shoulder, fell, can't lift their shoulder, has a big rotator cuff tear. Those ones actually do quite well when we fix them because it's hard to get you back to a normal shoulder when you have that acute traumatic event without fixing it. And then patients who have failed conservative treatment. So if you've had all the treatment that I'm going to discuss in a minute, you don't do well, then oftentimes you'll benefit from me fixing your shoulder. And as far as non-operative treatment goes, let's talk about my regimen here. Well, the first thing is physical therapy. Physical therapy, and I know a lot of people don't think it actually is relevant, but I've had it for my back a couple of times. It actually can help. And it's therapist dependent. Not all therapists are created equal. Some therapists are very good, some are not quite as good. And so we have to find you a good therapist. And we have a list of people around town that we think do a good job when we send you to therapy. But therapy actually can be quite effective in rotator cuff tears because it can help put the shoulder blade in a better position. It can help strengthen some of the supporting muscles of the shoulder to take stress off of those tendons that are torn. So actually people can do quite well with physical therapy. Anti-inflammatories are great. Rotator cuff tears in the shoulder cause inflammation, they cause pain. The pain can limit a lot of what you can do. So if you can take some anti-inflammatories to decrease the pain, that can help significantly. And to that point, oftentimes we'll try a steroid shot in the shoulder, and that helps drop the inflammation level down in the shoulder because it's kind of like putting a bottle of Advil into your shoulder. And that can oftentimes help take the pain down while you do the therapy effectively. Now, I will say the one caveat to doing a steroid shot in the shoulder is if I think I'm going to have to operate on your shoulder, if you're one of those acute traumatic tears where you had a fall and you tore your rotator cuff, sometimes I won't give you a steroid shot because we know that the results after surgery are slightly worse if you've had a steroid shot beforehand. And so in a lot of patients who we think we're going to get better with conservative treatment, meaning non-surgery treatment, we try the steroid shot. But if it's somebody who I'm really think is probably going to benefit more from surgery, and that's not a huge percentage of people, oftentimes they'll hold off on the shot. Sometimes we can just try the therapy and the anti-inflammatory by mouth. Now you'll hear other things about conservative treatment like injections that are PRP and stem cells and things like that. And I'll tell you, there's lots of people that do these. We do them sometimes for people who really want them. For rotator cuff tears, especially full thickness ones, there's no real good literature to support this. So I would say I wouldn't put you through the expense of this because I don't know if it's going to help you that much. Certainly is one of those things that's not going to hurt, but I can't tell you whether or not it's actually going to help you. And so we talk about physical therapy usually twice a week for about a month, month and a half. The anti-inflammatories, the injections, et cetera, that's kind of our regimen. And then we see how you do over about 6 weeks, okay? Now, if you do all these things and you don't respond well, then oftentimes you can benefit from a surgery. And there are different types of surgeries we can do for this. You can see here on the picture in the movie that's going here, that's what a rotator cuff tear looks like. That's the tendon that's torn off the bone. So that little grasper device was grabbing the tendon and pulling it back to where it belongs, because you can see when it's torn, it pulls away from where it belongs and it doesn't just heal on its own. This is why people ask, can these tendons heal? When they're full thickness tears, they don't, because they're not touching where they belong anymore. So that's why it's very hard for these tendons to heal. So the options for surgery for this, sometimes we can go in, and if it's just a small partial thickness tear, we can just clean the tear up a little bit by gently debriding it. And then sometimes we'll move your biceps because that can be a big pain generator in the shoulder. Obviously, the mainstay of treatment for big full thickness tears is we fix them. And I'll show you how we fix them in a minute. Sometimes if your tissue quality is not very good, we can also do these patch augmentation or balloon spacer things. These are just some newer, fancier things that have come out recently, and they're options if we need them. So they're a little more complicated, but they're options. And then sometimes you can actually transfer a tendon over if you have these chronic full thickness tears and you're relatively young. Sometimes I can move one of the other tendons in your shoulder over to function like the rotator cuff tendon that's torn. And if all these things don't work, or if you have a shoulder that is probably a little too far gone for these things, then the option is we do what's called a reverse shoulder replacement. I'll show you what that looks like in a little bit. So what the debridement is, it's arthroscopic. We make a couple poke holes the size of my fingertip and a small incision in the front over here. We clean up the frayed edges, and then we let the biceps tendon go, and we reattach it to the bone here to get rid of the segment that's been beaten up over time. And this actually can be quite effective in getting rid of the biceps as a pain generator, and also those partial thickness rotator cuff tears that are relatively small portion of the rotator cuff that's torn. This actually can do quite well. Now, this is what a biceps tendon looks like when I pull it out. This thing here is the biceps tendon after I've released it. All this stuff here is inflammatory tissue and partial tearing in the biceps that it's accumulated over time in people. And so you can imagine if we just left this in and took care of the stuff inside the shoulder joint but didn't address this, you'd have a tremendous amount of pain in the front of your shoulder afterwards. And so what we do is we release it from where it was, reattach this to the bone, and get rid of this entire segment that's been beaten up here. So that goes away. And then you still have a biceps that functions. Now, as far as the rotator cuff repair goes, this is arthroscopic. Over the last 15, 20 years, people have migrated from doing it open to doing it all arthroscopic. And I do these pretty much 100% of the time arthroscopic. And what we do is we clean up the edges of the tear and we reattach it to the bone with some anchors that go in the bone and some sutures that go through the tendon to bring it back to where it belongs. And patients actually do quite well for this. And this is what it looks like after you fix it. So you have some anchors that are in the bone. These are the sutures that go through the torn rotator cuff. And this is the same patient as before that you saw me pulling on that rotator cuff where it wasn't attached to the bone. Now it's nicely attached to the bone. And this is what we call a speed bridge configuration. And this patient did quite well. And again, I told you before, if everything else fails and we've exhausted all of our other options, what else can we do for this? Well, we can do what's called a reverse shoulder replacement, where we switch where the ball and the socket are. And the reason this is relevant is because we have what we call standard shoulder replacements or anatomic shoulder replacements. And that just keeps the ball over here and the socket over here. And that functions very well in people who have just arthritis with a very healthy rotator cuff. I did one of them this morning for a person who had a very, very bad arthritis, but their rotator cuff was functioning well. If I try to put a regular shoulder replacement in somebody who has a big rotator cuff tear, think about it, it's not going to work well because the rotator cuff functions to help keep the ball centered in the socket. And if the rotator cuff is not doing its job, the ball can start to slide out of the socket, the shoulder can dislocate, you will have a hard time lifting your shoulder up. So trying to put a shoulder replacement in somebody with a bad rotator cuff, the anatomic type, doesn't do well. The reason this reverse shoulder replacement, again, reverse, we're switching where the ball and the socket are, the reason this does well is because now we're taking away the need to have a functioning rotator cuff in order to power the shoulder. Rather, we use the deltoid, which is a big muscle on the outside of your arm here. That is now the functioning muscle that powers the shoulder because of how we've changed the geometry of the joint. And so people who have really bad rotator cuff tears that are not fixable, or who also have arthritis and a rotator cuff tear, this has been a great option. This has been around for a long time in Europe. It's been in the States since the mid-2000s. And we do quite a few of these, and patients do quite well from this because it's taking out the issue of the rotator cuff needing to heal. And so as far as what rehab looks like after we do the repair, right? I want to make sure you understand doing a rotator cuff repair is a long recovery, right? It's not like I do the surgery, you're better in a week. I wish it was. It's not like that. It's a few months of recovery that you're going to go through. And this is kind of what it looks like, okay? So for the first month, I don't have you start any physical therapy really, because I don't want you to really use the shoulder too much. We do a little passive motion where somebody's lifting your shoulder, but you're not actively lifting your shoulder, because if you go to lift it, you are pulling on my repair by doing that. And I don't want you to do that for the first few months because I want to make sure the tendon heals. After we hit the 6-week mark, then we can start doing some active assisted motion where somebody's lifting your shoulder, but then you're also powering your shoulder a little bit too and helping them. And then we start to progress after that. When we hit the 3-month mark, we start to strengthen your shoulder. So we start to get your shoulder muscles back. Everybody always wants to strengthen right away. And I tell everybody, don't worry, I promise you, your shoulder strength will come back. Motion is the most important thing in the first few months. Once the motion comes back completely, then we strengthen. If you're looking to get back to playing sports, usually in about 4 months or so, we can start having you do some sport-specific rehab using a golf club, things like that. Tennis takes a little bit longer because it's an overhead sport. And so to hit overhand takes more like 6 months rather than 4.5 months. But usually about 4.5 months, you can start playing golf. And generally by about the 2.5, 3-month mark, you actually feel much better than you did before surgery. You're just not fully recovered. And that's kind of what the rehab looks like. We call MMI, which is called maximal medical improvement. We say that usually you make most of your gains in the first year. So after about a year, that's all you're pretty much going to recover. But honestly, I'll tell you, within the first 6 months is when you make most of your gains, and usually you're doing quite well. And so that's kind of what it looks like from start to finish with a rotator cuff repair. I see you in the office, we have a discussion. Usually we'll start some therapy, plus minus trying a steroid shot. I see you back in the office in about 6 weeks. You feel great. Awesome. We're done. You don't feel great, then we get the MRI. We look to see how bad the tear is. If it's something I think you'd benefit from surgery on, and if it is, then we talk about fixing it. But that's kind of my algorithm for how we treat these, and kind of what it looks like when people do it. So just to kind of bring it home a little bit here, we know rotator cuff tears are very common. Okay, they are not always the source of the pain in your shoulder. A lot of times they can be. But just because an MRI says you have a rotator cuff tear doesn't mean that's the biggest issue with the shoulder, and doesn't mean you have to have it fixed. Okay, this is why we have these conversations, because I want people to understand that. All right. Generally, a trial of non-operative treatment can be very effective and is oftentimes warranted. Like I said, acute, big injuries with a normal shoulder before, and then you had an injury and the shoulder's very different. Those we fix. But the standard, I've had shoulder pain for a long time. I have night pain. I can still lift my shoulder up, but it's painful. Definitely a course of non-operative treatment. And then if you fail non-operative treatment, that's when we go into surgically repairing the rotator cuff. This jersey was, you have the Phillies thing on, but you can see the Mets thing here. The jersey was a gift when I covered the Mets back in 2017, 2018, and now I switched over. I covered the Phillies, so everybody here from New York, don't hate me. I still like the Mets, but Now I held out the Phillies. So this is just some future reference. If you guys have any more questions about stuff, there's some good books that we published recently that go over some of these things I just talked about. And thank you very much. This is my 18-month-old daughter. You know, I went to Notre Dame, so we try to start them early and put the hat on her here. She's loving it for about 12 seconds. Then she ripped that hat off. But it took about 30 pictures in those 12 seconds to make sure I got one where it looked pretty reasonable. So thank you very much. And you know, please, what questions can I answer for people? You know, this, you know, I threw a lot of information at you and try to make this interactive a little bit. So if you have questions, you want to talk about things, please feel free to, you know, hit me up with whatever questions you have.
Thank you, Dr. Erickson. Great presentation. Learned a lot. We do have a question from Peter. What are the chances for needing multiple rotator cuff surgeries on the same shoulder?
We know that in about 20 or 30% of the times we fix these, the rotator cuff doesn't heal. Okay. Now, in those 20 or 30% of people, only about 10 or 15% of them, of the people where it doesn't heal, continue to have symptoms. And so they wind up having a second surgery. So I would say it's a relatively low percentage. I, knock on wood, have had a few that we've had to go back in and do something on. Sometimes people have a rotator cuff tear 15, 20 years ago, they had it fixed, and they'll see me now in their 60s or 70s and it's kind of failed. And that's when we talk about doing the shoulder replacement. But I would say not common that we have to go back in.
Okay, great. Do you recommend any specific rotator cuff exercises before surgery?
That's a good question. So sometimes, you know, especially for things like ACL tears, right? We want to have somebody go to therapy beforehand. We do what's called prehab, where they work on getting their quad muscle back, because we know that the better motion they have when they go in, the stronger they are, the better they'll do afterwards. For rotator cuff tears, it's not quite as significant. So while I don't want you to have a stiff shoulder when you go in, you don't necessarily have to do as much kind of prehab beforehand. As long as you're, that's all we really care about. So you can have somebody stretch out beforehand. That's really the most important thing. And then from a strengthening perspective, really, if you can just do some shoulder blade retraction exercises, those are the best things. So if you take some bands and do some band work, you do some seated rows or lat pull downs, things like that, those will help strengthen up your shoulder blade muscles, and that can help.
Great, thank you. Can neglecting or getting treatment, can neglecting to get treatment, sucking it up, lead to issues with the elbow or overall proper form in sports?
Sure. So if you have a shoulder that's not functioning properly, other muscles around try to do a little more. So if you have a rotator cuff tear and you're starting to change your mechanics of your shoulder, your elbow and your neck can sometimes try to compensate. So you can get some secondary effects down the road. Now, to your point of like sucking it up and seeing how it goes, it's not necessarily wrong to do that. So time that can come back to bite you a little bit is if you have a full thickness rotator cuff tear, you treat it conservatively, you don't have surgery, and then you go on to continue to have pain, and you've done this for a couple of years. Now, again, sometimes that muscle can turn to fat, and then it changes it from something where I could have just fixed the rotator cuff primarily to where we may have to do something like a shoulder replacement or something like that.
Great, thank you. Another question. What shouldn't you do if the diagnosis with rotator cuff tear? Is it okay to cycle?
So, biking? Oh, absolutely. Yeah, cycling is totally fine. And lower body stuff, completely fine. Keeping yourself in good shape, totally fine. Rather have you stay active and do those things. Absolutely.
Okay, another question is, what determines the amount of time needed post-surgery before beginning PT?
So that's surgeon dependent. We've seen that there's no difference in long-term outcomes if you start therapy at 2 weeks or 6 weeks. You just get a little more stiff if you start surgery at 6 weeks. And so I generally start people in therapy at about 3 or 4 weeks after a rotator cuff repair. That way I give everything a little bit of a chance to heal, but I don't let you get too stiff. But that's really surgeon preference.
Okay, great. I have a general question for you. Why did you choose sports medicine?
It's a good question. So I went to Notre Dame for undergrad. I played football when I was there. I was a wide receiver. Broke my ankle when I was a junior. Had a bad fracture dislocation of my ankle, bone sticking out, all kinds of stuff like that. So I got a bunch of screws and a plate in my ankle now. And so that kind of introduced me to the world of sports medicine, team doctors and things. And so that kind of went down this path. Plus, I enjoy the surgeries on the shoulder, elbow, and knee. I find them very fun and interesting, and the patients are generally quite happy, and I get to deal with a lot of very nice patients.
Great, thank you. Another question. I was only ordered one PT visit for them to show me the exercise expected to do on my own twice per day for 2 months. Is that usual? Is that unusual?
Well, so sometimes a home exercise program can be very effective. Usually it's more effective when you have a home exercise program and also see the therapist and have them work on you too. So I would say if you can at least go once a week to the therapist, have them work on you, and then also make sure you're doing the home exercise correctly. I find that to be the best route usually.
Great, thank you. Next question. Can you utilize the same operative procedure for UCL tear as you treat a rotator cuff tear?
Slightly different. So the UCL, your Tommy John ligament in the elbow, right? That's a ligament as opposed to a muscle and a tendon. So tendons connect muscles to bone, ligaments connect bone to bone. So it's a different type of mechanics in the elbow that is in the shoulder. So when people have the UCL tear in the elbow, there's two different procedures we do for it. One is the standard Tommy John that a lot of people have heard of that watch baseball, where basically we make a tunnel on one side and a socket on another side and use a tendon graft to basically replace the UCL. A more recent one that we've started to do more of lately is what's called the UCL repair with an internal brace augmentation. So what we do is we put a suture anchor in, we repair the torn tendon to the bone, and then we put a very high tensile suture over the top and anchor it into the other part of the bone to basically give a backstop to the ligament as we repair it. And the reason that's relevant is because people can get back to playing a little bit sooner. So a little bit different than a rotator cuff repair, but similar in some ways.
Great information. Thank you. Next question. Are you using Regeneron or InSpace? If so, why is either one selected for a surgery?
So good question. That's a high level question. So InSpace is the balloon, that's Stryker's balloon that we use, or that has just been FDA approved recently in the last 6 months to use for rotator cuff tears. Regeneron, or you're referring to different patches. So I usually use the patches from Arthrex, but it's irrelevant. It's just the whoever you like to use. Those are two different types of things. So the balloon is basically like think of it like a boob implant that goes in the shoulder and kind of helps hold the humeral head down when you don't have a rotator cuff over the top. So you don't have the rotator cuff to help keep the ball centered. The spacer goes over the top to help try to keep the ball centered, while the other muscles around your shoulder start to retrain themselves to hold the ball centered. Pretty early data on that. So I use those in multiple revision settings as somebody who does not want to have a shoulder replacement. The patch that you're talking about, whether it's the Arthroflex, the Regeneten, or et cetera, those you can use to augment a rotator cuff repair if you don't like the tissue quality, or you can use what's called the superior capsular reconstruction, which is a piece of graft that you put on top and anchor it on the socket side and the ball side to help keep the head down. That kind of functions like a humeral head depressor as well. A little bit more stout than the balloon.
Thank you. Next question. What would cause the tear to progress?
So a couple factors. One, the size of it. So the bigger it is to start with, the more likely it is to progress. Okay. That's probably the most relevant one. And then of course, an acute injury to the shoulder. So if you had a tear and then you re-injured the shoulder doing something, that can sometimes cause an issue.
Great. I have another question from an attendee. What was the bubbles in one of the videos?
What was the bubble you said?
The bubbles.
Oh, the bubbles. So when we fix the rotator cuff, we pump a bunch of fluid through the shoulder. Same thing in the knee and the elbow and things like that. When we do arthroscopy, we put a bunch of fluid in there so we can see, and also so we don't damage your cartilage. And so when the fluid's running through the pump, sometimes you get some bubbles that go in there. You just suck them out with a little shaver. They don't go anywhere else. They don't cause a problem.
Great, good information. Thank you. And finally, how many days a week do you perform surgery?
I perform surgery twice a week, and then I see patients in the office 3 days a week. So I see patients in the city and in Westchester, and then operate both in the city and in Westchester.
Great. I think that is all our questions for tonight. I wanted to thank you very much for this great presentation. And I wanted to thank everyone who was able to join us this afternoon, evening, whatever you want to call it. For more information, or if you would like to make an appointment with one of our physicians in the future, you can visit us online at rothmanny.com, or you can call 800-636-7840. And just a reminder, we'll be sending out a recording to all the registrants within the next few days, so please be on the lookout for this email as well. And again, thank you, everyone. Have a great evening, and thanks for joining us.
Yeah,
Thank you.
and a quick thank you to John. Thank you for setting this up. Really appreciate it. And certainly, if anybody wants to reach out, you can always email me. John, feel free to share my email with anybody who wants. I'm happy to talk to you about it. Happy to see you in the office and chat about it. Sometimes it helps if I can examine your shoulder and give you a better idea of what's going on and see your imaging. So everybody have a great night. Enjoy the warm weather, and we'll see everybody soon.
Great. Thank you.
Take care.